Hello, and welcome to The Two View, the cutting-edge, informative, and interactive podcast for emergency medicine and urgent care NPs and PAs. I'm Martha Roberts, and I'm a nurse practitioner in Northern California, faculty for the Center for Medical Education, and professor of nursing. I am here with my co-CCME faculty partner, Mike Sharma, PA. Hi, Mike.
Hello, Martha. I'm Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area, and an adjunct professor of PA studies. We have been having a great time in the Sharma household. My two youngest daughters, Mima and Squish, had birthdays since the last time we recorded, so happy birthday, Mima and Squish. And summer is bearing down on us. It is definitely fly and mosquito season, greetings to all those who observe the season, which means my oldest, Geeka, is about to come home from college later on this week. It's going to be awesome. And just like many other video gamers out there, I picked up Helldivers 2. I'm loving it. There's nothing better for a break from my academic, schedule than logging on and killing giant bugs and Terminators. For any other Helldivers out there, I salute you, okay? Martha, you've just returned from fleeing the country. Was this for business or pleasure?
Well, we went just to have a good time, honestly. I needed to get out and do something. So I brought back a lot of memories and a lot of really great stories, but also this terrible cold. So I apologize for my poor voice right now. It could be really a lot sadder if I wanted it to sound that way. But I'm going to try to keep it strong today. So yeah, we're back for another episode of The Two View, and we're going to get right into it. So Mike, I want to start out with our first segment, and I'm going to say one word, and that is triage.
Oh boy, we have been circling this topic for a while, and we've been batting it back and forth for probably like years. And so I'm so excited to finally get into it a bit here.
Yeah, so we're going to mix it up here. We're going to do something kind of different for our spring edition. And we're going to get editorial. A lot of the discussion we have today is going to be very editorial-esque. And I'd like to put this piece out there kind of as our full segment and for our listeners to consider in regards to this introduction to triage debate that I think we're going to talk about for many shows to come. So do you think you can help me get through it?
Yeah, I was at Home Depot today. I went out and got a brand new milk crate that I could stand on for this topic. Soapbox is so 50s, right? So now I think the milk crate is where you go with this. So let's go ahead and do this. I'm ready.
Well, we could stand on a Nintendo Switch box because I did get a new one of those. Super Smash Brothers is what's popular in my house.
Okay, that's so small though. Like a Nintendo Switch box is like, I'd only be like an inch or two taller. So yeah, not
Well, you're
adequate.
pretty tall, so I'd give you that.
Fair.
So let's just close our eyes, but if you're driving, don't. And think about this for a second, right? The vibrant array of colored sputum, bodily smells, and unknown diagnoses sit in your waiting room triage lobby. If it's after 5 p.m., there are likely 20 plus people waiting if you're in a busy county hospital like mine, and a line of 10 out the door who have not even been registered. And as a triage APP, you have been tasked to successfully engage with, begin working up, and even treating dozens of patients so they can avoid, quote, getting a room in the back. Who really needs to be here? Your administration asks you. Nurses chime in. Can't this one just be discharged quickly? Further stating they just need a refill on some medication, which just happens to be methadone, olanzapine, insulin, and semaglutide. It's a nice mix, and I have seen that, by the way. As if that is a fast discharge, right? You are concerned you might be changing the way that you practice medicine and nursing, or PA-isms. You have to adapt to a new environment and other types of changes that is not conducive for patient care. This is not a healing environment for the patient, for you, for anyone around, and it's not safe for anyone.
Hey, at least that patient knew what they came in for, right? Like they're not wanting their blood pressure medicine that starts with an L. You know, the little pill, the small pill that starts with an L. So at least that person has a shopping list, okay? Well, let's zoom out a bit from your prescriber and triage role, which is a very common role for PAs and nurses or nurse practitioners to work in. Sometimes even physicians will work provider and triage in certain hospitals, but usually this falls to the PA or the NP. And let's think about kind of the setting we're talking about here. So any busy community or county County Hospital. Not one that I've ever worked for, or Martha has ever worked for, or not one that we currently work for, or will ever potentially work for in the future. Anyone listening out there, 2026. Anyways, take that busy hospital, that busy imaginary hospital that sees about 250 plus patients a day. For whatever reason, in this fictional hospital, there are staffing shortages on the nursing and ancillary staff. So entire areas of the hospital that actually could be open are closed, including parts of your ED. And as it does, the patient census surges and the inpatient teams reach their max nurse to patient ratios, despite there being physical beds. They're just not staffed beds, which is always the problem, is the staffing and not the furniture. So now we're boarding admitted patients in the ED, and these patients can be held in the ED that should be in the hospital for 24, 48, 72 hours, taking up precious critical care ED beds. And now instead of 80 available ED beds, there's like 40. And so the patients continue to be pushed out front, out the door into triage, where they wait and they wait and they wait for hours, potentially, with overcrowding. We know, we being medicine knows it has effects throughout the hospital. It's been studied. Of course, ED throughput goes down. Workplace violence goes up because that wasn't high enough to begin with already. One study suggests inpatient mortality goes up when we are ED boarding admitted patients, which, if you consider these patients boarding the ED are inpatients anyways, that makes total sense. And now it's back to you. You, as the provider in triage, have been given multiple tasks. First is to see patients shortly after they've completed nursing triage. This accomplishes multiple things, which we'll get into a bit, because it is a really important role, honestly. But in certain hospitals, there is a written or unwritten recommendation to discharge as many patients as you can before you leave your shift. This is not an easy role to play, except for the sickest of patients who are brought right back to a room. You're having to see every single patient that comes into your ED, making snap judgments on dozens of patients, more than you ever would encounter in a regular ED shift, and in less time as well. And for some people, you start dreading coming into work when you know you've got, you look at your schedule, you're like, oh, I'm in pit today. Oh man. And it takes its toll on some people. And you start questioning, is this why I went into emergency medicine, is to work in the pit?
So, we mentioned that, of course, this isn't about one particular hospital. And I myself have worked in a lot of hospitals. I'm not going to say anything negative about any hospital I've worked in. There's always been a positive aspect of every place I've worked in. But triage, I specifically want to talk about Fairfax County Hospital. It's one of the busiest, craziest hospitals in our country. And the paramedics that work in that county are fantastic. The emergency medicine physicians, many who have been there for 20 some years, fantastic.
And by the way, Martha, to butt in, Fairfax County, Virginia.
Yes,
correct?
Fairfax County, Virginia.
Very good.
Where I did some of my initial training. And the reason why I'm bringing it up is because they have a great system. They've always had a great system. I learned the most at that hospital. And triage, clinician, provider, whatever you call it, can be a blessing or a curse. So when you're a new graduate and you're working in triage, it could be like, oh my God, I don't even know where to start. But you get exposure to all these different types of patients, and then you get to follow them and see what happens. It really helps you raise your awareness. And if you've already been a nurse and had triage experience, you kind of already know what's going to happen to that patient. But the other part is, when I see that I have a triage shift, some of my colleagues in the past have said, oh man, like you said, I can't believe I'm going into triage. I'm like, holiday. It could be so nice. I mean, depending on where you're working, because it's like, okay, chest pain, no brainer. I know exactly what to order and work up. Like, this is an old person, not being ageist here, but this is an elderly person with chest pain. Like, we're doing the workup. Or like, we're taking bets on, like, is she pregnant or not? Like, what do we think based on her story? Like, these are fun and interesting times for me. It's a puzzle. Our medicine patients, I can follow a patient that goes back and be like, wow, they had ascending cholangitis. I was right. I'm glad I got them back right away. Anyway, I digress. What I'm talking about here in regards to triage being a curse is that bad things are happening. Not necessarily any place I've worked or you've worked, but the stories I've been hearing from clinicians around the country at our courses have been disturbing and very upsetting. It's in the news, not just our medicine and nursing news and PA news, it's in the regular news. So many of the patients who can wait up to 8 to 12 hours. In fact, Jefferson, way back in the day, had almost a 24-hour wait time to be seen. Now, this is way back before they created their big zones and these fantastic policies, which, again, I'm only saying accolades to them. Many people have put these things into place to make their business great. But people are still waiting 8 to 12 hours in busy county hospitals. Most likely, they're not going to die today, and they don't belong in your ED waiting room, which is another separate topic that I'm not sure we're going to have time to discuss too much about. But long gone are the days of critical care medicine and EDs, okay? We all know the job that we do today is 50% primary care, 20% psychiatric care, and about 10% critical care medicine. I mean, that's my personal, how would I call this? That's just basically what I've observed, right? I didn't take that from a study, but many patients who present to the ED are best suited for primary care, urgent care, a clinic. I mean, their life-threatening condition, rash for a year, and my mom had COVID. I didn't. I just want to get checked out, and I just need a school note. They all show up at the same time as that one cardiac arrest or that one stroke, that one stab victim. And we're allocating all our duties as advanced medical providers in kind of an unfair and inappropriate way. And unfortunately, some of our borderline critical care patients, such as early DKA or fractures or head injuries and arrhythmias, they kind of get lost in the not so sick. Sentinel events are increasing across the board. Triage clinicians must figure out who gets seen first, how fast, where, when. And our department is just literally exploding. Like you said, like we're just pushing patients until they're out the door. You know, and we're asking patients over and over and over again, you know, from the triage nurse to then the triage NP or PA and then to the doctor, how long have you had this? And can you tell me why you're here? And the patient just needs a simple solution, but they're not blessed with the knowledge that you have. This is what I always tell my students.
Right.
They're not blessed with that information, that they just need a Band-Aid, you know, so they seek ye first. Okay. And they wait, and they're going to wait in the ED for a long time. And we really take the brunt of the violent and abusive patients' mental health crises. And then again, this not meeting metrics business.
You had to go to the M word, huh? Metrics. Yeah. Chose violence. Okay, very good. Well, you know, healthcare in the U.S., you kind of hinted at kind of some of the problems here. Patients, even insured patients, face barriers that prevent them from getting the appropriate care. There's so many systems of systems that sometimes, you know, work really well, and sometimes I feel like they're kind of in the way. You know, we live in this increasingly specialized society. Like you said, you know, we are really blessed. We're blessed with the knowledge we have of medicine and advanced nursing. But in this specialized society, like we hire folks to fix our plumbing. We hire folks to do our taxes. And so like understandably, a lot of patients who have mastery elsewhere don't understand even the basic medical knowledge that we have spent years learning and we still are kind of mastering, you know. Beyond that knowledge gap, sometimes there's these social determinants of health as well that interfere with patients. Even when we give them, like even when they live in a very well-resourced county like San Fran, like Dallas County where I work, you can give them the resources, but there are these other things that interfere with their ability to use even low-cost or no-cost community resources. And, of course, add to that a primary care shortage, and to that the influx of preventable trauma, fentanyl, methamphetamine, xylazine abuse, smoking-related and other cardiovascular-related illnesses. All of these are on the rise. So much of what we see in the ER feels like preventable, like, you know, real own goal kind of stuff for our patients. And, but, you know, in between there are those patients who kind of like have really, you know, had an accident, have some sort of emergency that's no fault of their own. Not that it really matters whose fault it is. In the end, you have an emergency, and I'm an emergency medicine clinician, and so I'm here to fix your problem, or at least help you fix your problem. But do we have the time the ability, the resources, even in a well-resourced ED, to help a patient who's been struggling for schizophrenia or with schizophrenia for 30 years, somebody with a non-healing leg ulcer for 3 years, daily hunger that just brings them back again and again for turkey sandwiches. I don't know if any department has the ability to deal with these problems that some people seem to be plagued by despite resources. But we medicalize a lot of problems in the United States. And so a lot of these problems have been being in healthcare specifically, we are the point of the spear for these things. These problems are brought to us in triage, the PA, the NP, maybe they're new grads. And yeah, it can be a real dangerous environment. And Martha, you're concerned that it can't continue the way it's continuing right now.
No, it can't continue. I mean, quite frankly, this is not rocket science, and I could say a lot of expletives right here. It all comes down to administrations that don't want to change what they're doing or allocate funds or adopt a practice that's different. There's a variety of reasons why the things can't change. And it all comes down to staffing, which we'll talk about a little later. But in the end, it's like, so you're going to wait. And a very good NP friend of mine always says to the patient, like, I know you have a problem. I understand this, but you're going to wait. This is what's going to happen today. You're going to wait. And she always gets so animated about it. And I'm like, I love you for being honest with the patient. And they're like, fine, I'll wait 10 hours. I need this and I need it today. But I think my other problem, Mike, is not just this social determinant of health stuff that it may not be fixable right this moment, but the questioning and the wasting of the time and the wasting of the efforts. So like I mentioned, we're asking patients the same questions 5 million times. Again, I told you I was only going to talk about positive stuff. In Washington State, the Swedish medical centers, phenomenal, have something called the swarm method. And they bring in 5 people at one time. You know who those 5 people are? It's the doctor, it's the NP, it's the PA, it's the nurse, it's the social worker. It's maybe even the tech and the secretary. I mean, everybody swarms in. They get all the information. They have a scribe. I mean, these are easy things to implement and do, but no one wants to pay anyone to do them. And it pisses me off. But again, it's not rocket science. More staff. Ask the patients the same. No, don't ask patients the same questions over and over. And filter out those patients that aren't emergent through your channels of nurse practitioners and PAs and ancillary staff. So your physicians truly can do a lot of the critical care work and the stuff that emergency physicians do, which we're going to talk about in a minute. So let's talk about some of the things we've done to try to improve triage in various ways. We've sent doctors, more nurses, but not necessarily people who can discharge people. We need nurse practitioners and PAs and doctors to do that. We've sent EMTs. We've tried to kind of take care of this heavy buildup out front, but with a skeleton staff. And this really creates an unfair solution for our staff and for our patients, because there are some facilities, like someone I talked to in Detroit, they were like, it's not fair. Like when I'm in triage, I'm seeing 50 to 75 patients a day, while my buddy in the back carries 10 patients over 12 hours. I mean, it's absolute crap. So they dread going out there, and I don't blame them. It's not fair. So, one of the doctors I talked to in Florida, where some of their hospitals are really having a tough time because of their increased elderly population. Mm-hmm. They're like, I am so concerned about my license. Like, I can't possibly take care of all these patients. Well, by the way, my buddy in the back has like 4 active patients right now. Why is the staffing off so much? So patients hate to wait. Doctors hate to change their practice. And really, the liability lays upon this triage clinician. It's really intense. And the fact that more people aren't throwing their hands up in the air and saying, what is going on? This legal liability of the patients, it's really a huge anxiety, Mike. So patients are not getting the care they deserve. The clinicians are not practicing the way they should. What's next? A triage for triage? Are we just going to keep pushing patients out as far as they can go until they're not even in the hospital at all? And the role of the triage clinician is unique, right? So it's dependent upon the level of strength of that clinician and the nursing team. So let's say you're randomly assigned with like a group of nurses who, are notoriously like not into triage and don't like it or aren't good at it or they're brand new. Like your day got even harder. It's just this random assignment. And it's basically a crapshoot, right? That's what we call it, especially when we're in Las Vegas. It's a crapshoot. Well, ACEP is pushing for the door-to-doctor time to decrease as well as the left without being seen. Who is really benefiting from the triage provider? I feel like that one lone triage provider is just getting the crap beat out of them. Many criticize that placing APPs in triage is a mistake, especially if they're new grads, but it really depends, right? So many APPs are capable of treating and diagnosing non-complex cases and discharging them from the waiting room. The main problem is that the triage physicians are kind of caught between a rock and a hard place. They don't want them to take over, quote, the doctor job, which, again, we're not trying to do, but that's a lot of the discussion, as you know. Often patients need things in triage that they can't get, like our APPs can't get for them. It could be medications, treatments, other resources because there's no space. And then discharge is held up just for these things. Like there are hospitals where nurses won't administer any medications, not even a Tylenol in triage. So that patient has to wait because they're like, I want the pain medicine. I want it. So anyway, when the patient finally gets roomed, they get this dysfunctional, disjointed, expletive care. And how many times again, Mike, are we going to ask the patient, what brought you here today? And appease these patients, for their unsatisfactory wait times or apologize for an issue that we as a team missed.
I really have stopped asking patients like, okay, so what brings you in here today? I know. And so this is where I think that how you change practice as you become a more senior clinician, right? Like we're all taught in PA or NP school, you want to come into the room and ask the patient why they're here today and really let them talk for a while. But like you said, they've already answered that question at least 3 times before you see them, right? And so I think that I think it shows a level, or to some people, some patients, it feels like you are coming in there relatively incompetent. Honestly, it's like, do you not know why I've been here? Like, do y'all not talk? Like, what, So what I say, just kind of to talk shop real quick, I say like, hey, I'm Mike, I'm a PA, I'll be in charge of your care today. They tell me that you're here for blah, blah, blah. Like I tell them what they have supposedly told somebody else. And I look for them to say like, yeah or no, because I feel like that is a way to show competence to the patient to go, oh, this guy's coming in. He knows why I'm here. So great. Like this guy is already kind of off to the races with me instead of like, for reals, I got to explain this again to somebody. So anyways, I just kind of like want to bring that up for now in terms of if you the listener are in a place where you clearly see they've talked to the provider in triage, they've talked to the nurse triage, and they've told their story 2 times already. Go ahead and run with that story. Ask them, is this why you're here? Cut to the chase, in my opinion. Anyways, like you mentioned, Martha, the solution seems simple. Hire more nurses, open more rooms, staff triage with, and I'm going to get some flack from my PA and me brethren, put more PAs and NPs in triage, create more fast track areas. You mentioned scribes, techs, physicians doing more care and care delegation.
Well, yeah, Mike, I don't want to interrupt, but I do because I think physicians can do a lot of the delegating. I mean, why would you not put one physician and 3 APPs out in triage? What a fantastic model. I mean, again, super autonomous. I've been doing this for 2 decades. I have no qualms, if the doctor says like this patient is a patient that I want to see, or if I have a discussion with one of my colleagues that they're like, I don't feel comfortable seeing this, or, we share the load. So there's no reason why the physician can't say, hey, Martha, can you go see this ankle sprain? Because this other patient that's probably a STEMI, I'm going to walk back with them and contact the cath lab. Like, I'm just going to stick with this patient as opposed to handing them off. And that's the kind of camaraderie that you want. And quite frankly, that's what we have at the General. We have one physician and 3 APPs, and we're rapid fire getting stuff done.
In triage is where you have this crew.
Yeah, we just don't have a lot of nurses some days, and that's tough.
So it sounds like what you're doing is kind of like if you have a fast track-ish patient,
Right.
you are kind of like suctioning them off of triage to
Correct.
a fast track area for rapid discharge. Like you're prioritizing those patients' discharges.
Right. But like I said, the consistency, and it's not just my hospital. There's hospitals everywhere. The consistency and the randomization of who you're with that day can really determine how the day will go. Literally, if people will live or die, right? Because, you can't be precepting or training new people out in triage. It's very difficult. But anyway, I want to go back around to our current practice assigning triage physicians in general. I want to talk about physicians for a minute because they have a very difficult role. Even when they have APPs, it's still difficult for them because they're all over the place out there. What is bothersome to me is that we expect our physicians, sometimes just one physician, and I've seen that, no APPs out front, just one physician. We put them in this impossible role. And it's detrimental to all our oaths as clinicians. It's dangerous. It's inappropriate. And all the while, revenue-based care units and commission-based care models cloud the minds of clinicians trying to meet metrics. Until we can find a way to just simply staff an ED, the wait times are going to remain unbearable. The toll it's going to take on the staff will be immeasurable. And when your hospital has that sentinel event, who are you going to blame? But hey, your door-to-doctor time was 4 minutes. The C-suite is most likely never spent a day in your ER, and certainly hasn't spent a day waiting longer than 5 minutes for their cup of coffee from their local coffee joint. So I want you to think, like, if I brought someone, a family member, here to my ER, would I feel comfortable? What kind of care would they receive? Would they wait 12 hours? Like, what is this clinical role? And does it need more attention and improved leadership? This burden is super heavy.
Yeah, I wanna end about talking how I see the role and just how important it is. Frankly, we've kind of like I think we're dancing around like how important it is. We are kind of like suggesting how important it is because of the potential for a miss or a big win either way. So we'll get there. I feel like one of the lessons of the COVID pandemic is this staffing situation, right? There's a lot of healthcare settings that are staffing their groups to have just enough personnel. It's like that brittle patient that has, like zero reserve. They're fine and they get the sniffles and then they crash because like the sniffles are enough to throw them out of their very narrow window of tolerance, for their physiology. Okay. And they crash hard and they crash fast. And a lot of places were crashing hard in the early days of COVID. There was this perfect storm of like big patient volume. Staffing plans were failing because, number one, there just weren't the staff to take care of the patient volume. They didn't have this bench staff to activate. Top it off, staff is getting sick because, like, guess who's taking care of the COVID patients? The staff. And so they're getting sick. And then, like, some staff is getting fired because they refuse to follow vaccine mandates. Like, no matter, you've already had COVID twice, but we really need you to get this vaccine. Otherwise, we're going to fire you. Like, ugh, that is real insult to injury, in my opinion.
Yeah.
Even civilians are aware of these, the elite military groups out there. You've heard of like the Navy SEALs, the Army Special Forces. The military refers to these service members under the broad umbrella of something called SOF, Special Operations Forces. And these are people in the military who have been trained to a particular very high standard. And they volunteered to do things that others can't do or don't want to do. There is this concept out there of soft truths. And these are kind of, I don't know who coined these, but I think they're really smart. And they are these basically truisms about the optimal utilization of these special operations soft forces. Why am I bringing this up? I think medical leadership would benefit a great deal from considering these soft truths and how they can be applied to emergency medicine operations. And we'll link to at least one of these pages. You just Google soft truths, you'll find them. But we'll link to one of these pages at 2view.fireside.fm. That's our website, the number 2view.fireside.fm. The two soft truths that are most important here are, number one, special operations forces cannot be mass produced. And number two, competent special operations forces cannot be created after emergencies occur. PAs and NPs, physicians, nurses, we aren't just widgets that you can like order from Amazon and just get a bunch delivered to your door, within 1 or 2 days if you have Prime. It takes time to find talent, hire talent, credential talent, especially credential talent, because God knows that's not an emergency. There's no urgency there at all. And then train those talented individuals into a group that can work well as a team, because you've mentioned, Martha, the team dynamics, right? Emergency medicine is a team sport, and it's not enough to have a bunch of individual superstars. You have to have a team that works together. And that pool, by the way, from which, hospitals are trying to find that talent, that pool is finite. This group of people who are willing to wade into the unknown, to pandemic-infested waters and perform at a high level, there are a certain number of people who are willing to do that job. I really think it's really important that organizations, I hope they are looking at how things went during COVID, and maybe they can learn some lessons from those days, and maybe these soft truths from these military special operations forces that can lead to them hiring and staffing with reserve. Like, they need to have this reserve that can deal with, how many days of a week, of a month, where you get this massive, unexpected mismatch of patient volume to staffing. And then, at some places I've worked at, that is potentially an everyday thing. Sometimes it's an every week thing, an every month thing, but it happens over and over and over again. And I feel like some places expect it and staff for it. And those are the places that I really enjoy working, because for them, it's yes, this mismatch is expected and we can deal with it and it's okay. And there are other places that they're just shocked. Wow, we're just getting blown out of our socks again today. Who'd have thunk it? And they never staff for that. So will this staffing policy with a reserve that can flex, will that increase overhead? Without a doubt. But the consequences for failure in this mission are measured in obituaries. And they're not just patient obituaries, they're staff obituaries as well. This takes a toll on the staff in many direct and indirect ways.
Well, as I mentioned, I'm only saying positive things about places. At the General, we've come up with a whole triage initiative, a plan, a shout outs to Chris Caldwell, Malini Singh, Toph Peabody, Steve Straub. These people, they have put these things into practice. Multiple MPs we only have MPs right now, out in triage, one physician. And then we also have a survey that we can fill out. It's just with a QR code. Anybody can fill it out with suggestions. There's no punishment or it's anonymous, We have monthly meetings. We discuss this. We make changes. We're not perfect, but the NPs that work out there are amazing individuals with a lot of experience. And for our people that don't have as much experience, they're learning a lot from our population. But again, the medical team in a lot of hospitals, I was talking to a friend of mine in New Jersey, where literally the physician and nursing groups are so separate that they can't even talk, So, the physician team really wants to do stuff to improve their environment. But the nursing team is listen, we're doing our own thing, so don't tell us what to do. It's just a mess. You gotta have a protocol for nurses to give meds if you're not doing that. You gotta have a protocol to do EKGs and simple x-rays and labs. You gotta do that if you're not. This is an ever-changing environment that, like you said, we need to prepare before it happens. We need to think smarter. We don't need to be working harder. And really just think about ways we can innovate change in our department. And also we could start by making, a budget or actual training for triage. We can't keep ignoring it. We can't keep being in denial about it. And hiring for it should be upfront. Like you need to say, listen, you're going to spend shifts in triage because there are physicians. I mean, I worked with them in other states on the East Coast that say, I'm not working in triage and you can't make me or I'll quit. Right? So again, how is that fair? Anyway, as the late great Jim Roberts would say, if it were easy, everybody would be doing it. But I really wish I could ask Jim, while it doesn't have to be easy, can it just be functional, right? Can it just be functional? The dysfunctional system that we call the emergency department is in desperate need of repair. We can't fix the broken. We were broken ourselves. Like pushing our ED physicians and our APPs this hard in triage, you push them that hard, they're going to be pushed out the door too, really. So we want to know what you're doing in your triage. Tell us about it. Tell us about your triage provider, clinician, doctor, APP, or NP. Send us your thoughts to the 2View. The Gmail address is the number 2, viewcast@gmail.com. So that's 2viewcast@gmail.com.
It's really interesting you mentioned that. Like when I was coming on at my new job, I work at the Dallas County Hospital, Parkland, and as I was leaving, some of the people who were leaving, you could tell like their major dissatisfier was working in provider and triage, and they're like, "This is not." And I've worked in other places too, who like the provider and triage model was initiated at that group, and that person they were gone. They were like, "That's not what I'm here for." So I want to talk about that real quick. Like, to those of you who were in the pit with me, with Martha, because I work this role in my ER. I feel like half my shifts are there.
By the way, I love the role. I'm just putting it out there. I don't want to work in triage every day, but I freaking love it. I think it's a blast, but
I have a limit. I
Sure.
have to. I can't do a couple in a row. I have to kind of take some breaks, in my opinion.
Yeah.
Except for one person in our group, we all talk about the challenges of working in pit. This other guy's like, "Oh yeah, I'll do them all." Not necessarily, but I think because before I get into my section here, it's like you mentioned like there's room and need for innovation in provider and triage, like ways to handle things. And the guy who loves, at least he speaks how much he loves provider and triage the most in our group, he does do things differently, and like, there are results. Like he gets really interesting results and he works triage differently. And I think because of what he gets to do, he likes triage, Yeah. But in the end, regardless of whether he likes it or not, regardless if I or you like it or not, these are hard shifts, and it can feel like this. I call it. I tell my wife it's like this parade of misery sometimes. Like it's all this pressure.
No.
Like
Yeah, and I like to be like, "Oh, how was your day at work? All these preventable disasters came." Like it's just like, God, can you please?
just the line of slow motion car crashes. Yeah. It's just terrible. I don't know about you, Martha, when I'm doing a hard thing and I think about like, I could just stop doing this. I could quit. I could not show up. When I remember my why, like, why am I doing this hard thing? My purpose, it helps me not just survive, because a lot of folks are just kind of surviving pit, but it helps me when I know my why, I can continue that hard thing, not just to survive, but to have a degree of satisfaction and purpose in that thing. And so I want to talk about that real quick, because it may be that people out there, like, we all kind of like, good self-talk breeds more good self-talk, and bad self-talk breeds more negative self-talk. And so there may be this kind of feeling about pit in your group. And so I want to talk about it real quick. So how does pit matter? Pit matters at the individual level and at the system level. First, at the individual level, you have this training that you're listening here. You have this training that allows you to suss out these very subtly sick patients. Like, it's easy when someone has a bone sticking out of their arm and blood is spurting across the room. Those are the easy patients to say like, oh, that person looks unwell. But we have the training to suss out the subtly sick patient, or that patient who is like, they're okay now, but they're very high risk. And if I put them in the waiting room, I'm worried about them crashing out in the waiting room, even though they're fine right now. Like, the implications of what it means when someone says, I have primary adrenal insufficiency. or I have Marfan syndrome, or I have antiphospholipid syndrome, or I take an SGL2 inhibitor, T2 inhibitor rather. You know what those things mean, the subtle, like the second order knowledge that comes from those conditions. We're not any better or worse than the triage nurses. We just have different training and competencies. And so this is our training and competency to know the subtle things here. And if you, as the pit provider, play this game long enough, there are people who you catch in pit that have made it to you, and you say, this person needs a direct bed. They need to go back right now. Instead of sending them back to the waiting room for, again, 3, 6, 12, 24 hours. Because guess what? Not everyone who goes to the waiting room gets a bed. They'll walk out after an hour, 2 hours, 3 hours, 6 hours. And so they're going to do that, and they're going to bounce back even sicker, or maybe even in arrest, So sometimes I'll direct bed patients who are fine, but they're just so brittle, is the word I used earlier, that it's like, I just can't have this person walk out. Because, there is this, people talk about sometimes when people, they AMA, or they leave before they're seen, the kind of like, there is some dark humor that says like, if they really had an emergency, they would stay. Patients have no idea. Patients have no idea if they're having an emergency or not. If they did, a lot of us would be out of jobs, frankly, because they wouldn't need to staff the ER so much if people really knew, oh, I'm having an emergency. No, that's our job to help them work through. Okay, so just because they walk out doesn't mean they are okay. Because they have the physical capacity to walk out on 2 feet, they could walk out, they could crump on the sidewalk right outside of your ER. So you are going to save a life in pit. If you work pit out there, you're going to save a life in pit. You're going to save multiple lives in pit over your career. And when you think about these chains of people, how people are all interconnected, there's chains of people, there's networks of lives that are broken when somebody dies. And when you really think about it, you understand that saying, there are these multiple faith traditions that all say that when you save one life, you save the world. And I really believe that saying, and you're going to save multiple lives and change multiple worlds if you're doing a good job in pit.
That's some heavy stuff, really heavy stuff. But I have said this before on other podcasts. I always think about this doctor I work with, Trevor Talbert, who's always saying he's like a printer, right? He's always on idle. And when he hears those key phrases, like when you mentioned that, we have this knowledge and we have this special training. So a patient could be like, I've been feeling sick and I have this upper respiratory thing and a fever and, and I'm like, blah, blah, blah. Of course I'm listening. I'm being dramatic here. But then all of a sudden they say, well, I was recently diagnosed with tuberculosis, and printer turns on. It's like, hello. And like the printer's ready to go, and it's laser printer, like fast fire. And then I power down, and I just envision this doctor always telling me like, he's just always on idle, and these key words will like power him on, and he's ready to spout off this information. Anyway, I love Trevor. He was such a great person to work with. But
that's funny.
Mike.
Yeah, that's the emergency department, right? That is the emergency department is 8 to 12 hours of utter boredom punctuated by moments of sheer terror. Right? It's like, this is lame. Nothing's happening today. Oh my gosh, this person's about to die, or like needs to go to the OR, and we're back. We're back to just kind of like drudging through and like, can I, do I have time to eat a turkey sandwich right now, or do I have to go see patients? Yeah.
Well, you also have to really love your job. And I think like for me, you could put me anywhere and I'm going to try to have a really good day. I'm a flexible person, and I just really enjoy what I do, and you have to enjoy it. You have to really be present, and it's not going to be easy. Like, I'm not in a good mood every day, but I'm going to say like 90 to 95% of my shifts, I'm happy to be there. Like if you're not, and we've talked about this on prior podcasts, if you're really that unhappy that every word out of your mouth is a criticism and you hate your job, get the blip out of there. Like, stop it. You're just ruining everything. Like, just leave. Like, screw your pension. I'm sorry. The golden handcuffs. Can't stand that. Get a job
That's real, though.
that you love. I mean, anyway, it's easy for me to say that because I don't have a pension, and it's, I've saved money. I've saved money in different ways.
Right.
But I don't know, to be stuck at a job just because of a pension is such a sad, sad thing to think about.
I had a nurse that I used to work with, and every day, without fail, there would be a point at which she would leave a patient's room and slam whatever she was holding on the countertop, and she would say, "I quit." And the next day she was back again. And it's like, it's kind of funny. And at the same time, it doesn't make it easier on anybody around you.
Well, see, that's the thing, Mike. It's like, it was really easy for me to say, like, screw your pension. But like, I'm telling you, if you hate your job and you're miserable and you're working because you have to, quote, support your family or yourself or whatever, like, are you really that great of a person that you're suffering every day and making your family suffer in a job that you hate, in a world that's depressing and pathetic for you in whatever way you want to describe it, and you're slamming clipboards down every day saying you want to quit? Like, really? Like, I don't know. I've been lucky that I was able to find a job that I love and enjoy doing. I guess I just have a strong opinion about it, and I feel sorry for people that really hate it and have to show up every day.
It's really interesting that the way you speak about that. There was a phrase, and I'm remembering the second half of the phrase, and that second half of the phrase is "suffering is optional."
Yeah.
Like there is struggle and there's hard work,
Yeah.
and there are high stakes. We play a very high stakes game in emergency medicine. But the suffering that we put upon ourselves, there is at least there's a very high degree of optional suffering there that, and I hate to use the M word, but like there is some degree of mindset that you have to bring to the job. I'm not discounting people who have legit problems in their life.
Yeah.
I don't mean to say that like, oh, your kid who has or spouse or loved one or whatever has a substance use disorder, or your mother or father is dying, or your house is flooded. Like, I'm not trying to like ignore those patients. I recognize that a lot of us, like, life doesn't stop because we work in emergency medicine. Sadly enough, like, tragedies happen while you were on shift. That's when life happens, is when you're on shift. And so I'm not trying to like minimize those problems, but the day when those things aren't happening, because let's face it, like the most of the time those things aren't happening, and so the suffering that we have is optional, and that could be a whole other podcast, retreat, semester long class.
Absolutely.
And like how to deal with that. So we're just gonna move on from that, but I just wanted to drop that phrase.
Yes, and we can move on, but also I think I had a lot of health problems, mostly because I worked night shift almost my whole career. I loved it. I was a night person, but I was sick all the time with all kinds of things. I had arrhythmias, as you know, and I've talked about my Hürthle cell tumor, and I had all these other things that I had going on. But people forget that you could still keep your pension if you have one, and a large part of your benefits and other things if you go part-time. And for me, when I went part-time, I still kept my health insurance benefits, but I didn't work 3 and 4 12-hour shifts a week. I cut back, and that allowed me to go back to school and do more with pediatrics and get into the things that I really love. So it is possible to support your family and yourself financially in a job part-time. So you could consider doing that if you really hate your life right now. There's always a solution, as my mother would say.
I think, yeah, there very often is a solution, and sometimes it requires knowing the right people.
Yeah.
Which is, and again, not to go off on another big tangent here, but it's like, I am blessed to know the people that I know.
Especially
that
me.
Comes, like, I mean, honestly, no truer words have been spoken, Martha. Like, you say that like flippantly, like, I really do value our friendship and our partnership. But that's another podcast. We can save that one for the 100th episode anniversary or whatever else here. But let's just kind of get back to it.
Let's move on.
But anyways, the network is so important. So one of the reasons I like being on things like Facebook and Instagram and Twitter or whatever is developing a network, and why I like going to talk at conferences and travel, because I meet people who do really cool things. And if those people are doing really cool things and they know you and you're cool, they want to do those really cool things with you. And so as much as it can be additional work to do those cool things, I think that the benefits, there's just the investment is the payoff is way worth more than the investment is what I'm trying to say.
Yeah.
Anyways, I mentioned about the individual reason for your being in PIT. How are you helping people, individuals out there in PIT? Let's shift gears. How are you helping the system? Okay. So the system is so important here. A hospital-based emergency department, as you probably know, is mandated by the federal government under EMTALA, the Emergency Medical Treatment and Labor Act, to provide a medical screening exam to anyone who comes in. Are you a pediatric patient without your parents? Doesn't matter. I got to do medical screening exam on you. Are you somebody who has altered mental status, who can't pay? What doesn't matter. I am required to do a medical screening exam on you if that's what you want. In the majority of situations, that screening exam has to be done by a clinician. PA/NP physician, and RN triage is not adequate to meet that federal standard. If somebody comes in, and we talked about a case like this on our live show back in December, I think December. Somebody comes in, goes through nursing triage, goes to the waiting room, and doesn't get that screening exam by a clinician in a timely manner, the hospital can be hit with massive penalties, massive penalties. And maybe you're thinking, what concern is that to me? The hospital's got a lot of money. Well, guess what? Emergency medicine staffing organizations, they lose contracts. Hospitals close down. Hospitals close down all the time because of money problems. And your job, like it or leave it, probably hinges on your hospital staying open. And look around. How many other hundreds of jobs, thousands of jobs, tens of thousands of people depending on that hospital staying open? So, beyond the hospital as a system depending on you as PIT, if that's not motivating that like this hospital needs me, look around when you go to work. And these people all have people who depend on them, and all of them depend on you. So to those of you in the PIT, I salute you. I stand shoulder to shoulder next to you, regardless of how it may feel, this parade of misery. Your patients, your colleagues, they're depending on you in the PIT.
Yeah, so my little takeaway is, look at what other hospitals are doing, the ones that are successful, and replicate what they're doing, okay? See if it works. It may not be exactly perfect for your hospital, but don't reinvent the wheel. I also would suggest, like we said, coming up with some protocols that help your nurses, the staffing, big deal. Really embracing this team model, like we've talked about the physician and APP partnership. These things are really important to protect patient lives and help keep people in their jobs and liking their jobs, make them feel like they're worth something. And, again, we'd really love to hear your feedback. So shoot us an email at 2viewcast@gmail.com. And we are going to move on to our next segment.
Before we move on, I just got the notice that I got to put in my schedule for July, right? And July is a big month because it is our advanced emergency medicine boot camp. We're coming back to Las Vegas live. We took a year off for the advanced boot camp. It's come back bigger and better than ever. July 9th is our pre-course day, EKG workshop. Me and Fred Abrahamian Dio, I'll be teaching that EKG workshop. So come learn EKGs with me and Fred. There's an imaging workshop about how to be reading imaging yourself, interpreting, because that's a big deal. Like that can really speed throughput, is you interpreting images yourself. And also you can actually bill more in a way, okay? Like your MDM is beefier if you are doing the most basic of imaging interpretation independently. And then our main course is between July 10th and 12th. That's going to be our advanced emergency medicine boot camp. That's in July. You have a little more time, Martha, before you have to put in dates for your December absence for our original emergency medicine boot camp. Isn't that right?
That is correct. But I would say get on the ball, get things moving quickly so that you can come and hang out with us. Mm-hmm.
Yeah, that's going to be from December 4th through 7th. We have two, count them, two pre-workshop days, December 2nd and 3rd. There's an ultrasound workshop. There's a procedures workshop. There's a pharmacology workshop led by nurse practitioner Michael Gooch. So lots of things happening, even in the pre-conference days. The main conference, December 4th through 7th. Well, we are kind of doing things out of order here. So we're doing our first segment last, our usual first segment last. And so this is our wet read segment where we talk 60 seconds or so on something that caught our eye in the news. So let me go here about two things you'll find in most emergency departments: gallstones and point-of-care ultrasound. A systemic review and meta-analysis published in March 2024 in Annals of Emergency Medicine included 10 studies covering about 2,000 patient encounters in which emergency physicians performed point-of-care ultrasound to evaluate patients for acute cholecystitis. The study found a pooled sensitivity of 71%, with a 95% confidence interval ranging between 60 to 80%, specificity over 94%. This is not too far from the figures in this JAMA 2022 review of acute cholecystitis, suggesting sensitivity for ultrasound in detecting acute cholecystitis is about 80%. So short story, we can't hang our hat on a negative ultrasound in a patient who we think maybe has an acute cholecystitis. If you're working on a patient with an acute chole, potentially, you give them some aggressive pain management, especially if their LTs are even a bit abnormal. It's important to understand that we're not done after a negative ultrasound. Depending on your facility, your consultants, patient presentation, maybe you do a CT scan, maybe you just jump to surgical consultation, maybe you put them in OBS, or you consider potentially an entirely different diagnosis, okay? ACS, PE, pneumonia, malaria, even Fitzhugh-Curtis syndrome. Look that one up if you haven't talked about that one in a while. All of these things and more have presented to me personally as a right upper quadrant abdominal pain.
Yeah, those are all real good things right there, Mike. I have a lot to say about abdominal pain and cholecystitis and ultrasound, but all I can tell you is that if you don't feel confident about looking for or screening for these things in general, like when someone comes in for abdominal pain, you need to spend more time in triage. That's all I'm going to say. Spend more time in triage. Listen to how patients describe their abdominal pain, where it is. Break out your ultrasound. Take a look at all the quadrants. Look at the gallbladder. Do all those things, and you will be an expert with knowing if that patient really truly has life-threatening abdominal pain, appendicitis, something. In 1 month, I'm telling you, you will learn so much because you're going to see thousands of patients. So that's it. That's all I have to say.
It all goes back to triage.
Yes.
Time is a flat circle, as they say in True Detective, right on HBO. So yeah, I think it's a great thing. You kind of like say this, but like I want to like operationalize this. When you see a patient in triage and you're like, I wonder if they have whatever, go ahead and like place your bets. Go ahead and write it down. I think this person has whatever. Commit to it and then follow that patient and do that a couple of times a shift. And after a while, like you'll have the benefit of like getting a ton of reps in. And those reps are just so important in getting good at emergency medicine, seeing how these things, because sometimes you'll be like, nailed it. And sometimes you'll be like, whoa, that went in a totally different direction. I did not see that coming. Bizarre.
Yeah,
so
it's like you see someone sign in for like toe pain and then later they're diagnosed with like metastatic cancer and a brain tumor and like all these things. And you're like, oh my God, how'd that happen?
Right. I do the talk about upper abdominal pain at the original emergency medicine boot camp. And you can actually watch a version of that talk for free at ccmelive.org. That's our YouTube channel for the Center for Medical Education, www.ccmelive.org. We'll link to it in the show notes, so don't worry about that. TwoView.fireside.fm. Switching gears now to the PECARN head injury guidelines. We're all aware of the PECARN head injury guidelines. If you aren't, you should be. These help clinicians identify which children have suffered a head injury and can be safely spared a head CT because their risk of a clinically important traumatic brain injury. That's the phrase of the PECARN group. Clinically important traumatic brain injury. That is a traumatic brain injury that requires a neurosurgeon to do neurosurgery. That PECARN study or the guidelines for head injury allow us to suggest that, hey, these patients in this constellation of symptoms that they may have, it's so low that we can clinically exclude the neurosurgical brain injury just by doing a history and physical. So if you don't know what that is, we're going to link to the MD Calc and more information about the PECARN guidelines quickly in the show notes. But did you know the same PECARN group has a pediatric abdominal injury policy as well? It's not as well known as the head injury guidelines, but yeah, they do. And the PECARN group just published the results of a prospective, multi-center, external validation study for both of these guidelines. So these are the PECARN group comes out of UC Davis in California. These were non-UC Davis affiliated hospitals who all signed on to say, sure, we'll see if we can validate these guidelines. And so this external validation, which is so important for these studies, was in the Lancet Child and Adolescent Health Journal in the May 2024 edition. Almost 20,000 kiddos with head injuries, almost 8,000 kids with blunt abdominal trauma were included in these studies, and the news is just so reassuring. The traumatic brain injury rule for children younger than 2 had a sensitivity of 100% for clinically important traumatic brain injuries, and the traumatic brain injury rule for kids aged 2 years and older, because there is that break point, under 2, over 2. For kids over 2, the rule holds for 98.8% sensitivity in this guideline here. The second rule for the kiddos over 2 years old, that went 168 for 70. The 2 kids who were misclassified were admitted to the hospital anyways, but didn't need neurosurgery. So it's not really a miss there. The intra-abdominal injury rule had a sensitivity of, again, 100%. So when you use these guidelines, number one, you probably were already very reassured about how useful and clinically sensitive they were, but these studies just help reassure you that, yeah, like it's okay to not CT scan a kid and potentially give them radiation-induced brain cancer down the road. We know that kids are more susceptible to that sort of thing with that heavy amount of millisieverts we are shooting to their dome for these head injuries. So this should give you and the parents of these rugrats that you're taking care of some more peace of mind. But Martha, we can't really be dropping necessarily like, well, there's a pooled sensitivity and the whatever external validation. We can't really talk like that to patients. So like, what is your way when you have a patient in front of you, a kid that bonks their head and the parents are looking kind of nervous? What is your way that you break down this sort of stuff?
I mean, you say that we can't really talk that way, but I think that we can, depending on the population of patient. I think it's possible for you to show them the physical PECARN guidelines. I mean, it's really pretty. One's red and one is blue. I mean, you could say, for me, I say, I worked with this guy, Nate Cooperman, real good guy, real great guy, fantastic physician, very smart. Worked on thousands of cases of patients with head injuries. I've been doing this a long time myself. I'm pretty certain, based on these decisions that we're making today, that this is the right decision. And this is why, because, when we look at kids in these particular populations, like your child today, a really serious brain injury is not likely for them based on this criteria. Or the opposite, saying like, I'm really concerned because we have seen in studies for kids that have this particular symptom over and over again, or they've had altered mental status or something that makes them positive in the PECARN. I can't say with absolute certainty that there isn't something more serious going on. And I really think it would behoove us all, especially the child, to do more imaging or testing, or honestly, if there's ever a debate and you really can't make a decision, things are really hairline, say, I'd like to call, one of the attendings in. Let's go through this. And that's not me being like not confident, but we've talked about this on prior shows that sometimes patients just need a different face because they didn't like my face for whatever reason. And I really think it's the glasses sometimes. But to answer your question, I break out the pictures. I talk about my experience. I talk about what I would want for my own family or friend. And I know that a lot of people don't necessarily bring that into their practice. But I can't just be like, look, I think I'm smart. Okay. And I think I'm making the right choice.
Yeah. Yeah, I
So-
really I was talking online with some people, and I made the point that some people didn't like, and I said we're all in sales, and they're like, no, I didn't get into medicine to be in sales. It's like you are in sales whether you like it or not. You're selling treatment plans. You're selling why they should or shouldn't get these things done to them. And if you don't like Martha's way, if you don't like whatever my way would be, that's fine. But you have to figure out a way that works not just for you, but for the patient. Because guess what? If it doesn't work for the patient, they're going down the road to the next ER, and that person will do a CT scan on their kid. And then in 60 years, they're going to get this, splitting headache and vomiting and seizure. And it's like, wow, there's brain cancer. That's so terrible. If only we had known. And blah, blah, blah. These things happen, like what we do has like echoes into patients, later lives.
Well, with that, I would like to conclude because...
Let's conclude. I concur.
My throat hurts. So, my dog just scared the crap out of me. Sorry about that, Finley. Well, I hope that woke you up for our ending because I have some really important news, and it's our 2View trivia answer winner. Okay? The question was, Mike, you want to remind everybody?
Right. You can call it dermatoscopy or dermoscopy, depending on, potato. It's a relatively new way of examining things. Who first coined the term dermoscopy? And name one organization that has named an award in that person's honor.
All right, the answer was Leon Goldman. He was an American dermatologist and a pioneer in laser medicine, and his research areas included the application of lasers in dermatology, also some cancer photodynamic therapy, or PDT, and the use of organic dyes in photodynamic therapy. And in his honor, the American Society for Laser Medicine and Surgery gives the yearly recognition named Leon Goldman Memorial Award. And the Academy of Laser Dentistry also gives an award in recognition of Dr. Goldman, and it's called the Leon Goldman Award for Clinical Excellence.
Did you know there was a field of medicine called laser medicine? I want to practice laser medicine. I don't know what it is, but it sounds so cool. Can you imagine the conversations? Oh, you're a pediatric neurosurgeon? That's cool, but I practice laser medicine, folks. And don't even get me started on laser dentistry. What's laser dentistry? I don't know, but I'm pretty sure anything in this life is cooler when lasers are involved.
I just hope they could put freaking lasers on the sharks with freaking lasers on them.
I really think sharks' lives, quality of life adjustment for the sharks out there. I'm rooting for you, sharks. Get after it.
That's a great movie reference. Anyways, our winner of the month is Sarah Dice Goldberg. Congratulations, Sarah. She's a nurse practitioner in California, and she's going to be going with a free registration to our live ABC course this July. So going to be a rockin' time. Very excited. So new question, Mike.
Will it be a laser boot camp?
It's going to be laserific.
Laserific. Do we do a laser podcast? Can I say we do a laser podcast?
Sure.
Okay.
Yeah, let's
Done.
do it.
Laser podcast. Okay. We all know, new question, by the way. New question, you need to give us the two parts to this question, the two answers actually to this question. We all know that triage comes from the French word for sorting. But who was the first person back in the 1800s to use the French word trier to describe the process of medical sorting, and who did he work for? Who was it, and who did he work for? Email us your two-part answer in addition to anyone you want to give a shout out to, as well as any sort of feedback or comments about triage, our episode, to the 2Viewcast, 2Viewcast@gmail.com. That's the number 2Viewcast@gmail.com. Well, that is our show. Thanks for letting us opine in your ears about triage and the ups and the downs about triage. More information on the original and the advanced emergency medicine boot camps, the emergency medicine and acute care course, the mastering pediatric emergencies course. Who wouldn't want to master pediatric emergencies? Or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org. Thank you for listening and attending this podcast of the 2View. You can subscribe and rate us on Apple iTunes Podcasts, Spotify, and YouTube Music. I've been dealing with Spotify recently as my new podcatcher of choice. I'm not feeling it, Spotify. I gotta still kind of like work it a little bit. I'm just not having it right now. But anyway, search for 2View Emergency. That's the number 2View Emergency, and it will come right up in your podcatcher. Ratings help us climb the charts so that other clinicians get some 2View goodness like you are right now. If you like YouTube and you want to see Finley scare the crap out of Martha, if you want to see my fetching blue polo shirt, my mom got me this one. Thanks, Mom. It fits really nicely. You want to see the video blog instead? Search for Center for Medical Education on YouTube, or just go to ccmelive.org and you can catch the video version of our podcast. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to today. That's 2view.fireside.fm. Seriously, those soft truths, money. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thank you again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on the 2View. Have a good day and a great shift.
Enjoy Pitt.
Bye for now.
Bye.